So now we will start our workshop number 1, and this will be run by Dr. Manash Baruah, and he will speak on the clinical pulse for inpatient hyperglycemia management with special reference to insulin analogues. As we know, analogues are getting day by day popularity. So let's increase our knowledge by Dr. Baruah how it can be used in the hyperglycemia management.
Thank you. Thank you, chairpersons. Thank you, AAPON, for inviting me. It's a privilege to stand in front of Professor Sukumar Mukherjee. We all started our internal medicine career by listening to him, or listening about him rather, and later on listening to him, reading him, and then interacting with him after we got our degrees and all in different forums. So thank you very much, sir, for being fit and still with that command in your voice. I mean, that's what you need, and you should go on and on. And I see a lot of dignitaries. I won't name anyone individually. It's a privilege to speak something in front of you. So now we will move to the bedside, as Professor Mukherjee had suggested. Our interaction should be mostly about the bedside problems or the clinic-based problems. So, but today we are mostly will be inside the hospital, not in our clinic. So sometimes we'll be going back to our library for some references, but not most. So initially, firstly, I will go to library, because all your clinics at 11 a.m. in your morning rounds probably would start with some little bit of theories. Then your teacher would go on to discuss about the patient. So first of all, when you talk about inpatient hyperglycemia management, we must understand what are the different insulins which are available now. And this single slide will tell you about the insulin pharmacokinetics, which are very important to be remembered. But all the insulins are almost all are here. So starting with very long acting insulin, glargine, detemir, and then you have the NPH insulin, then you have the premix insulin. Of course, that is not much used in our hospital practice. This is intermediate NPH, which has a peak and the action is shorter, somewhere around 12 hours. But long acting insulin like glargine or detemir would act longer with a little bit of peak. And the short acting regular insulin is like this. So the peak comes late, and again the soldier effect stays late and it stays longer. But when the analogs came, like aspart, glulisine, lispro, we saw that the peaks are coming pretty fast, within half an hour or so, and there is no soldier effect, and the effect is going down sharply. That's why they are not causing any post-absorptive hypoglycemia, which should come after 4 hours after your meal. So postprandial, then post-absorptive. Postprandial is 4 hours, post-absorptive is after 4 hours. What came after this? This is somewhere around the first decade of this millennium. So what came after that is that very fast acting aspart, so-called FIASP, which is even faster. It starts acting within 5 minutes, and the soldier effect is even lesser than novorapid or aspart. So it is still better insulin to be used in hospital. And then you have the newer long acting analogs like degludec and glargine U300, which are having even lesser peak, and they are almost flat from the beginning till the end, and they are supposed to work even more than 24 hours. So very long acting insulin, and that's how the insulin would work, and this is a pharmacokinetics which is very important. I have this disclaimer and acknowledgement that many of the inputs had come from Arpandev, who stays in Bangalore, because myself and Arpandev, we did a workshop of this kind in last year RSS Day. I have taken inputs from him with his permission. So this is my agenda today. I will be talking about, I will introduce the topic and define inpatient hyperglycemia, and then I will ask these questions: why we should bother and how should we approach, and then I will come to the main part of today's discussion, the case scenarios in different wards, and then I will also bring up on the difficult situations which you might face in your day-to-day clinic, which are not discussed in CMEs mostly and which are not actually available in the literature. And then common mistakes, of course, that is very important. We make mistake and we learn. So what we can learn from these mistakes, and finally we need to discharge all inpatients. We want them to live happily after the discharge. So how do you plan your discharge? We will discuss about that, and then we'll have some discussion. We can have discussion in between. Chairpersons, please stop me anytime if you want. It needs to be discussed, or anyone can stop me. So I'll move ahead. The first thing, what is diabetes in hospital? So it is high blood sugar at admission, which could be capillary blood sugar, or it can be confirmed with a venous sample. Now that we all have glucometers available in all wards, so your first report which you will be receiving is capillary blood glucose, but it needs to be confirmed by a venous blood glucose for medical legal purpose, and also for your own. You can start acting on the basis of the glucometer blood glucose, because the lab report will take some time, at least half an hour to 1 hour. But then always remember, always tell your junior resident, please draw a blood and keep it for lab sampling, because you will have a medical legal requirement. You never know. So that is done. Then if your admission blood sugar or at any moment in the hospital is more than 140, the ADA defines it as a hyperglycemia, in hospital hyperglycemia, and that is acceptable to all of us. So when you encounter such a report, what are the possibilities? The possibilities could be patient of diabetes who could be admitted to your hospital. That patient could be type 1, type 2, or any other type. And this could be a newly diagnosed diabetes. Your patient was not known to have diabetes. Your HbA1c could be high, should be high rather, or it could be stress hyperglycemia, which is not because of diabetes per se, but because of the counter regulatory hormones and cytokines which are trying to help the patient to overcome the stress, and sometimes there's an overshoot, and that's why the patient is becoming hyperglycemic, because insulin or other mechanism for glucose control are not good enough to counterbalance the rise of those stress hormones. That's how it could be. So here HbA1c could be helpful, but I won't say HbA1c is a must for you, but it's helpful because it will differentiate the stress hyperglycemia patient from an unknown, undiagnosed diabetes or a known diabetic who has not been controlled well. Your HbA1c is high, means the patient had diabetes or he had poorly controlled diabetes. HbA1c is normal, when blood sugars are very high, that means it's happening on spot. That means now only the patient is hyperglycemic. So you can term that as stress hyperglycemia. So why should we bother? All patients are located throughout the hospital. It's not that the patients are located in your ward. It could be in the emergency. The patient could be in obstetrics, ICU, medical floor. Patient could be in the rehab, also in the, the patients are everywhere, surgical, cardiac. So that's one important thing. It's not a telemedicine phenomenon. It's not.
Manas, can I interrupt you?
Yeah.
Because you have shown this 140. So at this level, after a single reading of 140, can you say it is a in-hospital hyperglycemia, or you have to repeat another value?
No, I can say it's an in-hospital hyperglycemia, but I may not intervene. From the intervention perspective, we'll come to that later.
Yeah. Okay.
But your definition, because once you define that person as in-hospital hyperglycemia, everybody is on alert.
Yes.
There will be a follow-up. You need to follow up whether you act, whether you treat or not. There will be another cutoff, and it has to be repeated and confirmed. So follow-up will be done. So then just I'm going to the theoretical part, and why should we bother? The relationship between major outcomes like MI or major outcomes like all-cause mortality is always U-shaped if you compare that with blood sugar level. And you can see here, your blood sugar is lesser than 100, the curve is going up. It's more than say around 160, 70, 80 again is going up. So your patient, if they are here around 110 to 160, 70, 80, probably they are having the least mortality from any major cardiovascular outcome or all-cause mortality also. And that's why this concept of keeping the blood sugar tightly within that range, some people might try it even lesser, but again if you try it lesser, like less than 100, there is chance of increasing the mortality, and if you keep it, if you are complacent and keep it above 180, again there is a risk of mortality. So that's how the targets have been defined. So that's why it is said that mostly it is recommended that blood sugar target should be 140 to 180. It is a safe zone. In selected cases, it may be appropriate to keep it 110 to 140, especially surgical cases. Surgical mortality is better when the blood sugar is little lesser than medical mortality. So remember, surgical patients are healthy patients. That's why they are in surgery, except in emergency surgery. And why should a surgeon accept a patient when the patient is medically not fit? So they are medically fit, and there you can go a bit tighter. But for medical ward patients, they are sick. That's why they are in the hospital. They have got a lot of comorbidities. So there you should be less stringent. So that's how you will define your targets. And when you have this problem, you are keeping the patient in the target, how do you start anti-hyperglycemic therapy? 99% is going to be insulin. Whether the patient is critically ill or non-critically ill is generally recommended. What kind of insulin, what is the regime, IV, subcut, we will discuss that later. Oral agents are having minimal role except for very selected situations where the patient is getting admitted to some workup or something, but all medically or surgically ill patients should not receive oral agent. Very difficult to titrate. We usually stop them and switch over to insulin, except in special situations, as I said. And whether you discharge the patient with oral agent, that is against another issue, because mostly we find it more comfortable to go to an insulin regimen for some time, maybe a couple of weeks, then switch over to oral regimen in selected cases. And IV insulin, of course, it will be very widely used, unlike in your clinic practice where there is no IV role of IV insulin. Here you are going to use IV insulin quite a lot. We will discuss that again. Subcut insulin also will have role, but mostly it is in non-critically ill patient, not in critically ill patient. So there are different protocols. When you talk about IV insulin, there are different protocols, and they say that if you follow a protocol, or if you do not follow a protocol, just randomly give insulin, the patient's outcomes are always better if you put the patient into a protocol. And protocol can be set by anyone. All doctors sitting in a hospital, they can come together and define their own protocol, or we can follow protocols which are available in the internet, lot of them. So this is a Portland protocol which also showed that if you put the patient in insulin infusion as per protocol, then you get a better outcome. Again, the Leuven study, a very famous study, showed that keeping the blood sugar tightly controlled, and they targeted 80 to 110 in surgical patient, there was better outcome. These were all protocol driven, done by the paramedics, sisters, and intensive care technicians. So there also the outcomes were better. Nice sugar outcome also was compared to conventional intensive control was better. So protocol driven treatment has taken a place in our current practice now, and we should follow that. That's the important point I want to highlight. There was a nice paper coming up in JAPI, you all know, and J.J. Mukherjee was the chief author of this paper. So I will quote this for your benefit, because it is designed by Indians, so it is good for Indian setting. So this is how it would go. So if your blood sugar is very low, no insulin. But if your blood sugar rises, you can go in this manner, like 110 to 149, 1 unit. Likewise, I will not read out everything. It is available in JAPI, also in the internet, freely available. So you can follow this. And here again, you are not sitting there just to give the IV injection. Your sisters are doing it. You are just guiding them. And this can be hanged in your ICU or ward. And there are certain points which are to be remembered, that is important for the doctor. So first, in critically ill patient, again the definition is not 40 to 180, it's a spelling mistake, 140 to 180. In selected critically ill patient with hyperglycemia, such as post CABG or post surgical patient, 110 to 140 as I have already mentioned. Avoid aiming for blood glucose values less than 110. So that is important. Although Leuven protocol said that you can go up to 80, in our setting, I think 80 will be very dicey, sir, right? 80, you cannot afford to have many hypoglycemia, and I don't personally prefer less than 110. And when to initiate insulin therapy, when the blood glucose level is crossing 180, it is better to start insulin initiation. When if you put the patient on protocol, and if you start monitoring hourly, there is no fear of hypoglycemia, because the protocol itself will say that below 110, no insulin, so you are safe. Then recheck the blood glucose value before starting insulin intensive insulin therapy in patients with no prior history of diabetes. So if the patient is having only stress hyperglycemia and you are starting insulin because your target is more than 180 or less than 180, there you have to be very careful, because long standing diabetic will respond very slowly to your IV insulin. But stress hyperglycemia patient, suppose 350, blood glucose 350, first time stress hyperglycemia, you just give 2 units or 3 units of IV insulin, the blood sugar may drop. So subsequent hours you should be careful. Although it is said that after starting you go for hourly monitoring, in doubtful cases you may ask the sisters to check after 30 minutes also, before the insulin fully goes on acting and causing hypoglycemia. So these individual variations and your discretion should always apply. Guidelines are there to guide you, not to compel you to do something. Start insulin intensive therapy with short acting regular human insulin. You can also use fast acting insulin if they are available in vials, because it is very easy to draw and give it in the solution where you put the syringe pump. But it is not easy for the pen device, from the pen device to inject into the syringe pump, so we don't use this. That's why mostly you will find that you use human insulin vials, draw it by U40 syringe and put it inside. That's how you do, and that's the common practice everywhere, putting the insulin into syringe pump where there will be 50 ml of normal saline. Start insulin infusion by dividing the blood glucose value in milligram per deciliter by 100. This is very easy way to start. So an administration of a bolus insulin dose is not recommended, but some people practice that. I will show it through the case. So how you start, I will discuss it during the case presentation. You have to monitor every hour or more frequently, as I said. In suspect or doubtful cases, the blood glucose is falling very sharply. If the patient is very susceptible to hypoglycemia, you may monitor bit faster also. If the first blood glucose value is less than 70, you should stop insulin infusion, and you should look for hypoglycemia in subsequent hour or so. And in this situation, you might actually be monitoring every 20-30 minutes. Okay, and sometimes what happens, if you put the patient in IV infusion and the sisters will stop it when the blood glucose is 90, and when you come for a round, you find that for 6 hours blood sugar was never tested, and now the blood sugar is 500. So stopping the IV insulin flow does not mean that you stop the monitoring. Tell the sisters, even if you stop it, it is your duty to monitor every hour, because the patient has not been taken out of the protocol. It is within the protocol. We are stopping the IV insulin flow, but our monitoring must go on. That must be emphasized to the sisters, and that is a common mistake I see among the sisters. When they stop insulin infusion, they think that their duty is over and they will not go to the patient anymore, and their blood sugars will rise. So I have talked about having an infusion pump where you have the 50 ml syringe pump. So you use 50 ml normal saline and you inject 50 ml human insulin, rapid acting human insulin, and then mix it, and that is your insulin preparation. So 1 ml per hour is 1 unit per hour. What if you do not have the pump? And I know all hospitals will be having so many IV things going on. So vasopressors are going on. Sometimes nowadays, GI bleed cases, they have the somatostatin analogues are going on. A lot of things are going on. Syringe pumps are not so easy to buy. So in my residency days in All India Institute of Medical Science, we only had one syringe pump that was used for research purpose mostly, clamp studies. So we the resident, we design this calculation. I think this is going to be useful for some of you. And we have not used pump in our IV patients requiring IV insulin, but we did fairly well, I guess, because In my batch, at least, we didn't get that much of scolding from our teachers. So that was the final certificate for the resident. So what we do, if you add 50 international unit of rapid, 50 unit, it is 50 unit to 500 ml or normal saline. So we all know 1 ml is 20 drops and 20 macro drops, and 20 macro drop is actually 1 macro drop is 3 micro drop. So 1 ml is roughly 60 micro drop. This is a rough calculation. So now here the concentration of insulin is 100 ml is equal to 10 international unit in this. That means if you use 60 microdrop per minute, you are actually delivering 0.1 international unit. That means if you are using 10 microdrops per minute, then you are actually delivering 0.1 divided by 6. It is clear up to this part. Now in this rate, you now calculate for the whole hour. That is 600 microdrops will be delivered over an hour, and how much will there be in 600 microdrops? If you work it out that way, 600 multiplied by 0.1 by 60. So here 10 into 1 is equal to 10 microdrop. That means if you use this calculation, 10 microdrop per minute of this solution will deliver 1 unit per hour. 100 microdrop per minute will deliver 10 international unit per hour. That's how we can calculate, and this could be a very useful calculation in your clinical practice where there is no infusion pump. So if you don't have a pump, you should actually search for one, fight with a cardiology, gastroenterology and intensive care specialist colleagues that give me the pump, I need it. My insulin delivery is as important as your treatment. That is number one. Of course, that may not be possible. Otherwise, you can have this choice number 2 pretty jolly well. It may not be that perfect, but it works well. So what are the checkout list for transition from IV to subcutaneous insulin? So as soon as possible, you should go out of IV, because there is a tremendous work, load on your sisters and on you also. Just think about it. You're sleeping at home and your patient is getting IV insulin. If the sisters are making some mistakes, IV is going to go directly into the patient, and patient is going to have severe hypoglycemia. But if you are giving subcut insulin, the risk is less. The effectiveness also is less, but the risk is less. So IV insulin is protocol driven, it's okay, but it is still risky for you, and it's quite labor intensive for the sisters. Every hour they have to check. So you should go to subcut insulin or basal bolus insulin wherever possible, but the checklist is the patient should not be getting all these interventions like inotropes and mechanical ventilations. And patients should not be in acidosis. Mostly patients come with acidosis for various reasons, especially in diabetes. Patients should have a stable feeding pattern, enteral feed or Riles tube feed or oral feed. Should not have vomiting or diarrhea, where you cannot calculate the subcut prandial dose based on the patient's intake, because things are going out of the system also. Patient has stable blood glucose profile, and the patient's insulin requirement is not high. Suppose somebody is requiring 150 unit per day or 200 unit per day IV. I think that is not the ideal situation to go out of IV insulin entirely. You cannot convert 200 unit to subcut basal bolus so easily. So I think there you need to do something in between, which I can discuss later if time permits. I do something in between outside protocol. I give a basal fixed dose with the pump, because I have a lot of pump in my hospital now. So I keep a basal fixed dose going to take care of the basal dose and give some small prandial doses according to the feed, but that is different. But otherwise, patients should have reduced insulin requirement over the days when you are treating, then only shift to subcut insulin. So in non-critical ill patient, you can go for this calculation. Very sensitive patient, low calculation 0.3 unit per kilo body weight, and very much insulin resistant, you may have to go up to 1 unit per kilo body weight, or if they are in between, your calculation could be in between the moderately insulin sensitive. And the basal bolus, when you talk about basal bolus requirement, you must remember about 50% of requirement is bolus and 50% is basal when the patient is eating well. But in transitional stage, when the patient is receiving IV insulin and very sick or recovering from a severe sickness, the basal requirement will be high, because along with the original physiological basal requirement, there will be an additional corrective requirement because of stress, because the patient was under stress, had infection, and patient is not eating properly, had the patient may require 30% prandial and 70% basal if the patient is just coming out of a sickness. I will demonstrate a case to describe this. So it's individualized, and there are exceptions, as I have mentioned, in these patients. So again, if you initiate multiple dose injection, you starting total daily dose will be say 4.4 unit. The patient's weight is about 70 kilo or 67, you calculated is 28 units. Based on this calculation, 0.4 into 67, 28 unit. So basal dose, say we give glargine, the 50% of total daily dose will be 14 unit, and the prandial dose will be, if the patient is taking 3 meals, so it will be 14 divided by 3, approximately 5 unit. Breakfast, lunch and dinner. This is a rough calculation, but it works well. It's a rule of thumb, but then the thumb can move both ways depending on the situation, right? So there could be a requirement of correction bolus dose. So how to give the correction bolus dose? So what is that? So you fix the dose according to the rule of thumb. Now you have to move the thumb either way. So how you are going to do it? Again, there is a guideline. So what you do, if your pre-meal blood glucose is higher, you add this particular additional insulin to the previously fixed dose, which you did yesterday. Yesterday you fixed the dose of 555. Now your pre-meal is 300. So you have to make it 9 in that particular meal. And if the patient's requirements are high, you may have to go even higher, more aggressive. If the requirements are low, you may go a bit slow. So these charts are also available quite widely in the internet and also in the JAPI article, so you can follow that. These are useful pointers as to how you correct the pre-meal dose based on the pre-meal blood sugar on the subsequent days once you switch over to basal bolus regimen. So this is how you adjust the insulin on admission. So when the patient is admitted, you may have to reduce the basal insulin dose by 20 to 50%. And mealtime insulin coverage should be temporarily discontinued if the patient is NPO. Even for a procedure, endoscopic procedure, colonoscopic procedure, patient is NPO today, otherwise patient is fit. There also you may have to decide, these situations may arise. So small fracture management where the patients are kept only one day. Many times single day admissions or daycare admissions are required for 12 hours. There this situation may apply. Okay, but again, the blood sugar might rise throughout the procedural period. There again you have to use a correctional insulin dose every 6 hours and at bedtime, and your goal is to ensure proper application of the order. Your sisters may follow it. This is bit complex and quite variable depending on the situation, so there is no fixed guideline. So first you have to think about reducing in a not sick patient, stable patient admitted for a procedure. And then you have to use correction scale if the blood sugars are rising. So that's how you go ahead with this. So now we come to the case scenarios. I think these are going to be interesting for you. So I will start with a medical case, very typical medical case. So this is a patient with acute lymphoblastic leukemia with neutropenic fever and admission HbA1c 7.2, not very high. And this is how the insulin requirement varied. See, the requirement was rising at the middle of the stay and gradually falling down. And if you divide these insulin requirements, you can divide it in deep way. This is the part when the patient was getting IV insulin, and this part is patient is getting prandial insulin. You can see here, and the basal insulin is in black. So the start with patient was on IV insulin. This is how it was there. Initially low requirement, then it went up at the peak of the illness, then it gradually came down when medically the treatment was taken care of and patient's fever came down. Here the requirement is changing because here you are switching over to basal bolus, and you can see the basal insulin requirement is also coming down. Why? Because the patient's pre-admission HbA1c was how much? So 7.2 is a good control. So this patient actually does not require much insulin. So you have to be very careful during these days of recovery. There will be sharp, although the blood sugar requirement is very high at the 7-day peak of illness, that does not foretell you as to what would be the requirement. You have to calculate that in the background of HbA1c value. That's how it is going to help. This patient's requirement, basal requirement, ordinary situation is not very high. That's why the basal insulin requirement is coming down, and finally only the prandial requirement is there. So the prandial requirement also is coming down. See, finally this is a good patient to be discharged with oral drugs. Nowadays we have a lot of safe oral drugs, probably a DPP4 inhibitor and a very low dose of gliclazide or glipizide could be useful in this patient. This patient probably won't require insulin. So this is one patient and one example from the medical ward. And just to highlight, normally a patient requires basal insulin, which is a physiological basal requirement, and a prandial insulin, which depends on how much you are eating, and the corrections insulin requirement is very less, which might vary according to the stress of the patient. The patient may undergo stress level, the stress level may be less today, more tomorrow. During moderate sickness, the correction requirement because of stress is higher, and the basal requirement also is higher. During very severe sickness, when the patient is not eating, the prandial requirement becomes 0. There is no prandial requirement. But you are giving enteral feed, rice tube feed or total parenteral nutrition to the patient, so there will be a nutritional requirement. Actually, nutritional requirement is replacing the parenteral requirement, but the basal requirement remains high because of the stressful situation, and the correction requirement is also there. So this is how 3 types of patient will actually behave in terms of insulin requirement. So everything is not similar that way. So this correction requirement and basal requirement will come down to the baseline level, which was there during health after the recovery from the illness, and that has to be kept in mind. So let's move to a surgical case. So this is a patient whose preoperative sugar levels, interoperative sugar levels and ward sugar levels just after operation has been demonstrated. So intravenous insulin per protocol was used. So nice maintenance of blood sugar, little bit of fluctuation is there, but it is quite satisfactory. Fine. The patient goes to ward, and from here onwards the ICU doctors are not monitoring the patient. Patient is being monitored in the ward and is monitored by the ward resident who is not much experienced. And in the ward, sliding scale insulin was given. See how it is rising and falling. It's a roller coaster ride. Again, a specialist internist was called in. He used basal bolus insulin with correction dose. Again, it is gradually coming down. So what I try to emphasize is that if you follow a protocol in the surgical ward and a basal bolus protocol with a correction dose, correction scale, post-operative period, and not follow sliding scale insulin, then actually you will do better. And many of your surgical patients would behave like this. That's why I have mentioned this case. I will not go into the details. It is just any surgical case could be like this. So this is a bit a longer case in an ICU patient. So very interesting points are there. So this is a patient, diabetic patient for 8 years, insulin degludec 18 and empagliflozin metformin, presented with typical features of COVID-19, and there were no other comorbidities except diabetes. So because the SpO2 was low, patient was put on non-invasive ventilation as per the guideline around that time. Admission blood sugar 330, the ketones were negative, and there was no acidosis to start with, metabolic acidosis to start with. Here long-acting basal insulin OADs were stopped and IV insulin infusion was started, and your target was 140 to 180 in this patient because he is medically ill, and this ICU followed this particular protocol. As I said, you may not follow a typical protocol, you may make your own protocol. So initially to start with, this calculation may work. Actually, please notice carefully. divide the initial glucose level by 100 and then round off to the nearest 0.5 unit. In this case, patient had 330 divided by 100. So, around 3.3 or 3.5 unit would be the first bolus dose. First IV bolus of first aspart administered, and then your rate also starts with that. Infusion rate started with first aspart at 3.5 unit, and subsequently you follow this protocol driven adjustment in the subsequent period. Patient was also administered DNS 5% and potassium 40 milliequivalent at 100 ml per hour, that is for the support. And why potassium? Any patient who is on insulin, IV insulin, if the patient doesn't have anuria, if the patient does not have high creatinine indicating CKD, you must give potassium. Especially patients who are admitted with acidosis must be given potassium even at the level of serum potassium of 4.5. Why? It is acidosis. When it is corrected, the potassium will be driven into the cell and the patient will have severe hypokalemia, driving the myocardium crazy, and patient may actually be lost when you are metabolically correcting everything. So, that has to be remembered. Potassium correction, except in anuric patient and advanced CKD patient, is a must in all IV insulin patient. Fine. So, this patient had this kind of blood glucose, you can see here on day 5 and day 6, and patient was on Riles tube feed, and patient was given 50% of intravenous requirement as basal, that is 20 unit degludec here after recovery from the acute severely acute part, and 50% of IV as a 20 unit, which is divided by 776 as subcut unit FIABs. So, what happened? The blood glucose, postprandial blood glucose peaks were there. Okay. So, oral, in this situation, patient had a gastritis, loose motion, and patient was getting doxycycline, which is notorious to cause a lot of diarrhea and GI side effects. Patient was not eating well. The oral feed was withdrawn and prandial FIABs were withdrawn and Riles tube feed was initiated. So far the patient was not doing so badly. All blood glucose were less than 200. So what happened after that? The blood glucose postprandial started rising almost to the tune of 300 after Riles tube feed, because you have withdrawn the prandial insulin. So how to reintroduce the prandial insulin? You can see here, along with each Riles tube feed, because Riles tube feeds are not going to be 3 times a day. They are going to be either 2 hourly as the dietitian prescribes, or it could be like 4 hourly carbohydrate, and in between there could be protein and fat. You can have that kind of, at least 4 major feeds are there in all hospitals, all ICUs. So here the role of fast acting aspart or fast acting Lispro, which is recently available, would come. This is a true case actually, based on a true case. Here I used 4 injection of fast acting aspart, and you can see that the postprandial rise are coming down nicely after giving, these are 2 days, no? Day 8 and day 9, within 1 day of giving fast acting aspart without any hypoglycemia. If I had used human insulin 4 times like this, there could be some hypoglycemic phases in between. So that's why it is safer to use faster acting aspart. They work fast within minutes. So after Riles tube, the absorption of food is also very fast. It also works well along with the Riles tube feed. The Riles tube feed is liquid. It's not going to stay in the stomach for a long time. So it is also not going to work in your circulation for a long time. So it quite matches well with your Riles tube feed. So here the role of analog would come. They are very useful tool in such kind of patient, frequent meals, etc., small meals. Okay. So let us now talk about the difficult situations. I will not take much time. So steroid is very important. We are all confused as to, I am confused, during COVID time, it was so difficult to control the blood sugar of all diabetic patients, because after high dose of glucocorticoids, the blood sugar would rise. So there are certain guidelines, and we all know that glucocorticoids are counter-regulatory all along, from the very beginning of hypoglycemia and also long term. Catecholamines are only in the short term, growth hormone and glucocorticoid in the long term from the point of view of hypoglycemia, working against hypoglycemia, because they work in the liver, increasing gluconeogenesis, They also decrease glycogen synthesis, it's a long-term effect, and also increase lipolysis, again a long-term effect causing hyperglycemia. So there are pharmacological factors which are very important. It depends on the dose of the drug. So steroid-induced hyperglycemia would be dose-dependent, and if you cross the physiological levels, especially in situations like multiple sclerosis or AIDP or COVID for that matter, you are actually giving very high dose. So apart from that, otherwise pulse therapy also there. Sometimes we give 3 days pulse therapy in different malignancies and immunological conditions. There also the blood sugar can go haywire. And it also depends on pre-existing diabetes mellitus and patient having increased risk of diabetes, etc. So what you should do, if glucocorticoid therapy has been recommended, it's good to go for a SB1C at all the patients who are at higher risk. If the SB1C says that the patient has got pre-existing diabetes, so monitor blood glucose 4 times when the patient is on glucocorticoid, or if there is no pre-existing diabetes, you can monitor once daily, because you never know, a potential diabetic may become diabetic after giving glucocorticoid. His SB1C could be normal, but still the patient can become diabetic after giving glucocorticoid. So if your blood glucose on 2 occasions more than 11.1 millimole, that is, you can multiply that with 180, so almost around 190 or almost reaching 200, more than 200 on 2 occasions, then it is glucocorticoid induced hyperglycemia. If it is not so, and if it is so, that you can say that the patient is having glucocorticoid induced diabetes. So how you actually treat them? So glucocorticoid induced hyperglycemia in pre-existing diabetes like type 1 diabetes, you have to go for basal bolus insulin and up titrate AM bolus by 10 to 20%, and up titrate AM dose by, if the patient is on BID insulin, which they are not mostly, type 1 diabetics are mostly on basal bolus. So up titrate the morning dose by 10 to 20%. If the patient is type 2 diabetic, not insulin requiring, you may start with a shorter acting sulfonylurea like gliclazide and also glipizide, which is a forgotten drug but very good drug, around breakfast time, and up titrate to a maximum of 240 milligram OD. The interesting fact is that glucocorticoids orally are given in the morning, and they are expected to raise the blood sugar post breakfast, sometimes till post lunch. So we can try with a morning dose of relatively shorter acting drug like gliclazide instantly in the morning, and keep on raising the dose, not giving the dose in the evening, even if the pre-dinner blood sugar is high, because after 1 AM in the morning, patient may have a severe hypoglycemia when the glucocorticoid effect is gone. In addition to this, it's a good practical idea to give a premixed insulin, maybe 50-50 type of premixed insulin before breakfast. If the patient is insulin requiring, then you should shift the PM insulin to morning insulin. Even if your basal insulin is given in the evening, you can now shift to morning insulin till the blood sugar is there, and you can go for basal bolus insulin, and you should concentrate on the AM bolus insulin, pre-breakfast bolus insulin only, mostly, not the post-breakfast, I think. Okay. So I think I will quickly go through the mistakes, common mistakes. So I can conclude then, except for the common mistakes, 2 interesting mistakes I needed to show actually. This I have already given. So one is that sliding scale insulin, as I said, it doesn't serve any purpose. So we should go for protocol driven insulin, and so sometimes it is seen that the sister would draw insulin from the pen and try to inject it. We should remember that these pens contain high concentration insulin, U100 or U300 nowadays, and your pens are having U40. That means if you are drawing it from the pen, you are actually injecting 2.5 times higher amount of insulin that could be very dangerous. That is one thing to remember. And next is not respecting electrolyte, very important for us clinicians. Suppose this patient comes to you, if your blood sugar is say around 700 or 600, serum sodium is around 125, and the resident calls you, patient is having hyponatremia, should I start 3% normal saline? Should you? No. You have to correct it by a factor of 1.6 per every 100 milligram per deciliter blood sugar above the mean value. That is, for 700 blood sugar, additional is 600. So 1.6 into 6, that is that amount of sodium you have to add to the lab value. Actually, this is a pseudo hyponatremia of hyperglycemia. And second, as I said, potassium replacement should start early. We should not wait till the potassium comes low, because that could be too late. And finally, very funny mistake, sometimes we write the U, and in our hurry the U becomes O, and your 2 unit can become 20 unit. So that mistake, and this is Arpan's idea to put this slide, and there's a real happening in their hospital. You can see that, do not write U after insulin dose. If you write, what I do, I write the insulin in figure like 5, then encircle it, and then write the U or unit, whatever. I usually try to write units, because U sometimes can become O, and that could be even fatal in some patient. If you are giving say 9 unit, and because of that U becoming O, it is 90 unit, what can happen? So remember that. I think with that I will end my talk. Discharge plan, of course, it again takes some time. You have to plan it properly. You have to see whether the patient can inject at home or not. That is again your duty, because you write 4 injections, whether the patient is able to do that or not. Many times we have to give the insulin only and not tablets. So the planning I couldn't cover because of the time constraint. But I think the practical issues which involve all of us inside the ward, inside the hospital ICU, I think main points I have covered. Thank you very much.
Thank you, Dr. Baruah. Excellent deliberation, and this is the bread and butter for the doctors practicing in the hospital, particularly in the ICU. There is a time constraint, but still the issue is so important. 1 or 2 question or comment can be allowed. Yes, Dr. Sandeep Mandal.
I'm making an honest confession. See, after practicing for more than 20 years with the diabetes, whenever I have heard a lecture on the ICU setup, what is the protocol, I become more confused. What I have understood, make the thing very simple. If a patient admitted in the ICU cannot take anything, if you need IV insulin, try to keep it as short as possible, because whenever you are giving IV insulin, you have to also take care of the potassium and other things. If you even forget all the formulas, the patient is, you are starting IV insulin, start with any protocol and gradually up titrate or down titrate the dose of the insulin so that you can keep the blood sugar under control. It may be 140, 180, you may keep even higher to 200, because if the patient is unconscious and you are planning for a tight glycemic control, patient, even if there is hypoglycemia, it may be identified. Second thing is, whenever the patient is able to eat, convert it in the subcutaneous insulins, you give a basal supplement and you give correctional or prandial, and titrate the dose depending upon the fasting plasma glucose and 3 postprandial plasma glucose. Simple.
Yeah, actually, you have raised a very important point. Don't bother about the protocols. In a very hyperglycemic situation in ICU, you have to control the hyperglycemia by giving insulin. That doesn't mean that you have to be very smart and do it within 12 hours. You have to tell the attendants that, see, I have controlled your blood sugar. And that is wrong. All diabetic complications like hyperosmolar state or decay, they are controlled by very small unit of insulin. Remember, small units, 10 unit or 20 unit will bring down the metabolic decompensation. Then you go slowly, take your time. You don't have to be a hero on the first day.
And second thing is that regarding
Yeah.
particularly in the space in COPD,
Yes.
in asthma. So I think there is no questions of the glycolized and other things. In hospital setup, we always prefer insulin, and depending upon how much the blood sugar will shoot, because again there is variations of variability of the patient. If you use say 50 milligram of the corticosteroids twice daily for patient, again there is variable of the rising of the blood sugar.
Yeah. Yeah. Just because it came up, so I think very important for us to remember. But long-acting glucocorticoid users, they are prone to hyperglycemia, but they are also prone to severe hypoglycemia. Why, you know? Once you use glucocorticoid for 4 to 6 weeks, their own adrenal axis is going to get suppressed. And these people, if they miss the glucocorticoid dose for even 1 day, they will become hypoglycemic, severe hypoglycemic. So always remember that. Sometimes they come with hypoglycemia, not hyperglycemia.
That's good.